Yeah, good morning, everyone. I am Dr. M.I.M. Shuja, lecturer, the Department of Physiology. And today's lecture is on circulatory shock. As we have some issues with our Zoom account due to this current situation, I have been forced to use the private Zoom account. Okay, so your lecture will automatically end it after 40 minutes. And again, it will reoccur, or there may be a discontinuation of the video. So bear that and stay with me. So when you hear the term shock, what comes to your mind? This is an electrical shock. Then there is she received a wonderful surprise news. Then she's again in shock. There are different kinds of shock. So what actually in the medical terminology shock is decreased perfusion to a cell resulting in cell injury. To complete a circulation or the cells to get oxygen, you need a heart. And there should be a blood vessel where the blood runs. And it reaches the target. Your heart is pumped, the blood has to run in, and it reaches the actual site. If these three functions happens, then your cell will get oxygen. It will help in production of the ATP and the cell survive. If there is any problem either at the pumping level, the heart, or the fluid, that means the blood, the amount of blood, or the tube, the character of the or diameter of the blood vessels. All three is having an impact on your perfusion. So if there are any problem occur in either of these three, it will lead to a problem in the cell perfusion. That means loss of oxygen, less ATP, eventually cell death. That we call circulatory shock. So this is what they say. Either the problem in the heart, like M.I.M, toxic heart, or valvular disease, your heart is unable to pump the blood needed. We call it circulatory shock. Other thing is your heart is functioning well, that is okay. But the amount of blood coming via the circulation, the preload, is not enough. As there is a reduction in the preload, what will happen? There will be a reduction in the cardiac output. When there is a reduction in the cardiac output, there is a less amount of oxygen reaching your cell. Then it will lead to no perfusion and cell death. Those are the two basic concepts. Either problem in the heart or either problem in the blood, the amount of blood, the oxygen carrying capacity of the blood, or the problem in the diameter of the blood vessel. If it's too much of vasodilation, you cannot pump to the certain place, because when there is too much of vasodilation, the resistance is reduced. You need a certain amount of total peripheral resistance to maintain a blood pressure. That means mean arterial pressure. Other term for the mean arterial pressure is perfusion pressure. So when there is a total peripheral resistance is reduced due to the vasodilation, what will happen? The perfusion pressure is reduced. So the perfusion is going to be reduced. That will lead to cell death. So this is just a diagram, just see for the basic understanding. We assume the flow is equal to pressure. So if you have adequate flow, there's adequate pressure. That means if you have adequate blood flow, there's the adequate perfusion pressure. Your cell will get adequate oxygen. So there is no shock. If there is inadequate flow, inadequate pressure, hypoperfusion, that is shock. As I mentioned earlier, there are three main components. That means your heart, the pump. What are the causes of inadequate pump? Either inadequate preload, either poor contractility, or excessive afterload. Your heart is trying to pump, but the afterload is opposing that, or inadequate heart rate. Then second thing is problem with the fluid volume, that is blood, hypovolemic. Then container, that means your blood vessel, either excessive dilatation or reduction in systemic vascular pressure. These are the major causes that will eventually lead you to the reduction in the mean arterial pressure or perfusion pressure. When there is a reduction of the perfusion, the oxygen reaching the cell is low, so that will lead to cell ischemia, cell death, that we call shock. It is characterized by a mismatch between oxygen delivery and the demand. So subsequently, there is a mismatch and low tissue perfusion, inflammatory markers are released. That will further impair tissue perfusion because the inflammatory markers like cytokines, interleukins, they tend to have a vasodilatory effect. So they further reduce your perfusion pressure. So further impairs your tissue perfusion. So that will eventually lead to cell ischemia. If you treated at that time, the cell survives. If you are unable to treat that level, eventually cell going to die. There are four major types of shocks, depends on the mechanism. All the type of shocks eventually causing reduction in the blood pressure. Reduction in the blood pressure, that is reduction in the mean arterial pressure. Mean arterial pressure means perfusion pressure. So when there is a reduction in the perfusion pressure, your cells are not get adequately perfused. So that will lead to cell or shock. Four basic type of shock: hypovolemic shock, cardiogenic shock, obstructive shock, distributive shock. Hypovolemic shock, as the name implies, the volume is reduced. So before thinking about this, you have to remember two equations. One is cardiac output is equal to heart rate and stroke volume. Amount of volume the heart ejected and the rate per minute. That is your cardiac output. Other equation is blood pressure is equal to cardiac output times total peripheral resistance or systemic vascular resistance. So if you can apply these two equations, then the explanation of the mechanism of the types of shock is going to be very easy, like scholarship student stuff. Or as I always say, Baba stuff. So hypovolemic is reduction in the volume. Cardiogenic is the problem in the heart. It unable to contract like it usually does. Then obstructive. There is some obstruction to your cardiac output, or there is some obstruction which is blocking your refilling of the heart. Then distributive shock. Distributive means the distribution. What distribute the blood? Blood vessel. So if there's a problem in that line, vasodilation of the blood vessel, that may lead to a shock. That is distributive shock. These are the four basic types of shock. In the distributive shock, you will have neurogenic shock, anaphylactic shock, septic shock, and psychogenic shock. The neurogenic shock is a wonderful, a different phenomena. It doesn't have a sympathetic response. But that means it will cause bradycardia. But other shocks, initially, as a compensatory mechanism, they will tend to cause reflex tachycardia. Okay? If we have another chance to do this lecture on site, we will do elaborately, but this lecture also is going to be a full elaboration of septic, not the shock. So remember, circulatory shock, it can be either due to low cardiac output, hypovolemia, pump failure, obstruction, or there may be high or normal or low output. That is distributive. In the distributive, you have neurogenic, anaphylactic, septic, or toxic, psychogenic. Hypovolemic shock is a result of the insufficient circulation in the blood body. So what are the ways you can lose your volume, your body? One is excessive vomiting. Other one is excessive diarrhea, excessive sweating, third degree burn, mainly the third degree burn, and a trauma causing bleeding. So those are the ways your blood volume is reduced. Cardiogenic shock is the amount or the ability of the heart pumping power is reduced. Maybe your heart is having an M.I, so cell death occurs, so it cannot able to contract. Okay, so if it cannot able to contract, the preload is there, but it cannot eject certain amount, so your afterload is going to be, what will happen to afterload? Okay, what will happen to end systolic volume? You have a preload in the heart or in the ventricle. That is end diastolic volume. Then you have to pump it. That is stroke volume. And after you pump the stroke volume, there's a certain amount of blood is going to stay in your ventricular chamber. That we call end systolic volume. So if you are unable to pump the stroke volume fully, end systolic volume is going to be increased. So when the venous return comes for the next cycle, with that preload, these increased end systolic volume, they combine together and the preload is increased for the next confinement. If it happens in the vicious cycle again and again, it will cause a overdistension of the heart. It will end up in cardiomegaly and other issues. So the reason for the cardiogenic shock are M.I, heart failure, and arrhythmia. Obstructive shock, either due to the obstruction in the afterload or increased afterload, or there's a reduce in the preload because of the obstruction. Like the tension pneumothorax and cardiac tamponade, they are going to constrict the heart. So what will happen? The heart is already constricted, compromised. The filling is not complete because you don't have enough space. So that will lead to reduction in the preload. If you have pulmonary embolism, your artery is blocked. So you have enough blood when you are pumping, the block is due to your pressure, that is afterload, increase afterload. So you are unable to send the stroke volume, or your cardiac output is reduced. Then the distributive shock, it is defined by vasodilation. So when there is a vasodilation, your peripheral resistance is reduced, so your blood pressure is reduced. That will cause hypotension. There's other mixed shock status, like you can have cardiogenic shock and a septic shock in a person. That will rarely happen, but there are entities like that. Just know it. So these graphs, you have to remember very easy. So remember very carefully, blood pressure. The blood pressure is decided by cardiac output times peripheral vascular resistance. Cardiac output is decided by heart rate and stroke volume. Stroke volume is decided by the preload, contractility, and the afterload. Imagine in a hypovolemic shock, what will happen? There's a loss of blood. That means when there's a loss of blood, there's a reduction in the venous return. When there's a reduction in the venous return, there's a reduction in the preload. When there's a reduction in the preload, the stroke volume is going to be reduced. When there's a reduction in the stroke volume, the cardiac output is going to be reduced. When there's a reduction in the cardiac output, blood pressure is reduced. So the low blood pressure, low mean arterial pressure, low perfusion pressure, your shock. Like that, if it is a cardiogenic shock, your contractility is reduced, so it will eventually go to reduction in the blood pressure. In the anaphylactic shock or septic shock, what will happen? That is a distributive shock. So peripheral vascular resistance is reduced. So blood pressure is reduced. In generally, stroke volume is decided by end diastolic volume and end systolic volume. End diastolic volume is mainly decided by preload. When there is an increase in the preload, the stroke volume increases. When there is an increase in the afterload, the stroke volume is reduced. When there is an increased inotropy, that means contractility of the heart, stroke volume is increased. So what is preload and what is afterload? Okay, tell me what is afterload? Afterload is the pressure exerted on heart. That is, the pressure or the load of something weight is going to oppose your heart's pumping ability. That is afterload. Another term is afterload is the pressure exerted on heart by heart. Okay. So this is just a diagram show when there is a bleeding, your cardiac output and arterial pressure is eventually coming down. But initially up to a level, even though up to a 10%, the blood loss is occurs, the cardiac output is maintained. So that is normal. Up to a 10% of the blood loss, your body can be able to maintain sorry, or regulate the cardiac output. So you have studied the baroreceptor reflex mechanisms and everything, and you are good with blood pressure regulation. So understanding this is not difficult. This is just a graph. That's a diagram shows what will happen when there is a decreased cardiac output and how it again become a vicious cycle. Just go through this, you will understand. So what are the mechanical changes and cellular responses in shock? First thing is there's a reduction of the mean arterial pressure. That means reduction of the perfusion pressure. So there's a reduced capillary perfusion. Because the capillary are the place where the oxygen from the blood is diffused or transferred to the tissue. So when there's a reduced capillary perfusion, reduce oxygen. So anaerobic mechanisms are coming to the action. So when there is anaerobic metabolism, there's a lactic acid formation. So metabolic acidosis. When there's too much of acidosis, there's a pH is reduced. So when there's an acidic pH, your channels, pumps, your enzymes cannot function at their prime. So their failure in the sodium potassium pump. Sodium potassium pump is the primary pump which keeps your cells almost alive. So that failure eventually leads to anions imbalances, cation imbalances, and it will lead to the lysosome, nuclear membrane, mitochondrial breakdown, and cell death. And after 3 to 5 hours of shock, there's a precapillary sphincter dilatation, blood stagnation, and hypoxia is continuous. Because of the hypoxia, there is acidosis and everything. The fluid leaves the extravascular compartment, maybe due to the impermeability. It further reduces your circulating blood volume. Because of the hypoperfusion, there is a granulocyte accumulation at injury vessel. So free radical release, further tissue damage. If you don't get enough blood to your gastric mucosa, damage to the gastric mucosa, it allows bacteria into the circulation. Because your gut is a barrier protecting bacteria entering your blood. Then if there's a reduced blood supply to your brain, there's a depression in the vasomotor center, so it will lead to vasodilation, reduce heart rate, and further reduce your blood pressure. If there's no enough blood to the heart, it will causes M.I.M. If there's the metabolic acidosis and your oxygen is low, your lungs need to work more hard. One is to expel the carbon dioxide, other one is to get more oxygen. So your respiratory rate is going to be increased. These mechanisms will eventually, if they fail, is a kind of protective or regulating mechanism or compensatory mechanism. If they fail beyond a certain limit, there's a multiple organ failure and death. So there are stages of shock, 3 stages. One is non-progressive stage. As I said in the graph, up to 10% of the blood loss, the arterial pressure and cardiac output is maintained. So full recovery of that. If the 10% is passed, the blood loss is more than 10, 15, 20. There's a progressive stage. That means your cardiac output is further declining. But if you can treat, that if you treat the cause or give blood or water or fluid, something, if you can regain the volume, if there's a hypovolemic shock, then you treat, then you prevent the death. If you are unable to treat in the progressive stage also, it will lead to death. And at beyond one point, there is irreversible. At the irreversible, what will happen is we cannot treat, we cannot cure. So treatment failure and they will die. There are 3 stages. One is non-progressive, body itself can manage. Second, progressive, we have to find the cause, we have to treat it. Third is irreversible. These are the three stages of shock. Know that it may come in exam. There's a graph, as I said, the cardiac output is initially maintained up to certain. Then it start to reduce and it reduce. That is the progressive stage. At this stage, if you give transfusion, the cardiac output is going up. So you are safe. But beyond this level, it is irreversible shock. So if you give blood at this level, it won't give any effect. So the patient will die. Three stages: initial, non-progressive, progressive, and irreversible. Hope you understand these things. These are very important. Just allocate 2 or 3 minutes to get the concept of this. Non-progressive, progressive, irreversible. Non-progressive, body itself can manage. We don't need to treat. Progressive, we have to treat. Irreversible, even though we treat, it becomes pain. So, what you have to do is you have to identify which stages of shock a patient is on. That's what we need doctors. Because the patient comes and say, "Hi doctor, I am in shock. Now I am in a reversible shock state. Can you treat me?" They don't ask like that. They come in shock. We have to monitor the parameters and we have to identify at which stage they are on. Okay. So hypovolemic shock, as we mentioned, the reduction in the cardiac output may be due to the hypovolemia, due to the decreased blood volume, hemorrhage, any surgery, burn, especially third degree, fluid loss due to vomiting, diarrhea, excessive condition. So how the human body responds to acute hemorrhage? They activate 4 major physiological systems. One is hematological, second is cardiovascular, third is renal, fourth is neuroendocrine. Both neuroendocrine. So hematological system is activating the coagulation cascade because you are bleeding, your body needs to reduce the hemorrhage. So it activates the coagulation cascade. I have taught you in the blood physiology part how this coagulation cascade is activated and working. Then cardiovascular system. Because your volume is reduced, stroke volume is reduced, your cardiac output is reduced. But the cardiac output is stroke volume times heart rate. So if the stroke volume is reduced, the heart rate needs to shoot up to maintain the cardiac output. So there's an increase in the heart rate, again increase in the myocardial contractility and constriction of the peripheral blood vessel to increase peripheral resistance. So these response occur secondary to an increased secretion of norepinephrine and a decrease in vagal tone. That means your sympathetic activity is going to increase. So it will vasoconstrict, it will divert the blood to the vital organs. What are the vital organs? Brain, heart, kidney. And it will send the blood away from the skin, muscles, and your GI tract. Renal system, when there's a hemorrhagic shock, the renal perfusion is reduced, so the renin is secreted. It converts angiotensinogen to angiotensin 1, then angiotensin 1 converted to angiotensin 2. This angiotensin 2 will do several activities that will increase your blood pressure. So this is just a graph, just go through this. Don't worry, we are going to study this in depth in renal physiology, but you know this. Then the reduction in the blood pressure, juxtaglomerular apparatus secrete renin. It converts angiotensinogen to angiotensin 1. Then angiotensin converting enzyme changes angiotensin 1 to angiotensin 2. This angiotensin 2 will act on adrenal cortex, increase aldosterone secretion, so salt and water is reabsorbed, and it vasoconstricts the arterioles and increase the blood pressure. Via vasoconstriction, blood pressure is shoot up. Via aldosterone, blood volume is increases. So the blood volume increases, that increases your preload, that increases your cardiac output, that also increases your blood pressure. So the neuroendocrine system, the ADH secretion, ADH is act on collecting that and it secretes or it reabsorbs water. So the blood volume is increases. That eventually increases the stroke volume and cardiac output. You just go through this. The dehydration of the loss of blood volume. Don't forget about salt ingestion. Dehydration, blood volume is reduced. When there's a reduction in the blood volume, the water loss, the blood osmolality is increased. Osmoreceptor activated. It increased secretion of the ADH. It acts on kidney, reabsorb water. Then the osmoreceptor in the hypothalamus increase thirst. We drink more water. That increases the blood. This is just a diagram. Just go through this. You will understand. This is the basic concept of how the hemorrhagic shock or hypovolemic shock. Compensating the blood. So this I said the stages of shock 1, 2, 3, 4. They basically depend on the volume of blood flows, the blood pressure, respiratory rate, and pulse rate. See the stage 1, less than 15% of the blood is lost. Still, blood pressure is normal. Heart rate also normal. With other stages, it changes. You just go through and know this. The percentage of blood loss and what happens at each stages for the pulse rate and blood pressure. So with that, we have studied the basic mechanism of action, the basic pathophysiology of hypovolemic shock and other shocks. So what will happen in a hypovolemic shock? What are the clinical features? Due to the low amount of perfusion, that means hypoperfusion, that causes the low perfusion to the extremities. The extremities become pale. Because of the vasoconstriction, due to the hypoperfusion, the extremities become cold. So always cold, clammy, pale extremities in hypovolemic shock. Or the shock causes the reduction in the perfusion. And there's a sustained hypotension. Weak rapid pulse as a reflex tachycardia as compensatory mechanism is active. Increased respiratory rate, I have mentioned why is because of the metabolic acidosis, compensating for that and for the hypoxia. Sweating, because the sympathetic drives are activating, autonomic system is activated, so sweating is happening. Increased thirst, your osmoreceptors are activated. Oliguria, because you don't have enough blood in your system, so there is reduced renal perfusion, so reduced urine out. Metabolic acidosis and restlessness, lactic acid. These are the features You should know, you should be able to explain those features. These are the few signs and symptoms you must remember. Restless or drowsiness, increase in thirst, rapid respiration, hypotension, pulse rapid and steady, cold, pale, cyanose, clammy skin, low urine output. So these signs and symptoms you should know, and you should know the pathophysiology behind these signs and symptoms. How shock causes these symptoms. Okay. Tachycardia and cold due to the low volume and hypotension. Baroreceptors are less stretched, so stimulation is reduced. So increase sympathetic discharge, reduce vagal tone, so that causes increased heart rate. Hypotension because of the low volume, low central venous pressure, so low venous return. It will lead to, according to the Frank-Starling mechanism, reduction in the preload, low stroke volume, low cardiac output, that leads to low blood pressure. Thirst. Angiotensin to activate the osmoreceptor, hypothalamus, thirst. Low urine volume. Low volume of blood, increased sympathetic discharge, hypothalamus getting activated, ADS secrete, water retention, and again increased sympathetic discharge, renal vasoconstriction, reduced renal blood flow, water retention in the renal blood, low renal blood flow causes decreased urine output. So we can divide this compensatory mechanism into immediate, long-term, and immediate and long-term mechanism. So immediate mechanisms are mainly to maintain the perfusion of the vital organs. Long terms are to restore the tissue perfusion back to normal. Then we have rapidly acting mechanism. They act within seconds. Mainly neural mechanism, sympathetic fiber. Baroreceptor reflex, chemoreceptor reflex, central nervous system ischemic mechanism, reverse stress relaxation. And intermediate mechanism acts within 30 minutes to several hours. Brain angiotensin system and capillary fluid shift. Then the long-term mechanisms act within hours to days, mainly humoral mechanism, plasma volume restoration, plasma protein restoration, and red cell marker. Now we are going to look each one by one. Yeah, the rapidly acting mechanism, the baroreceptor reflex. So you know what will happen, how the baroreceptor reflex is activating when there is a reduction in the blood pressure. So you just go through that, we see that. Vasoconstriction occurs, renal constriction occurs, then chemoreceptor reflex. When there is reduction in the mean arterial pressure, less than 60 millimeter mercury, acidosis and hypoxia occurs. So that will stimulate central and peripheral chemoreceptors, and it enhances the carotid body's activity and respiratory stimulation occurs. Don't worry. This chemoreceptor reflex will be taught during your respiratory module, especially in the regulation of the respiration. Just know this, these are things going to happen. Then central nervous system is ischemic response. This mechanism will activate when arterial pressure is less than 50 millimeter mercury. So more powerful sympathetic discharges the heart and blood vessel. The heart rate is increases, blood vessel is lesser constricted, blood pressure is rising. Then the reverse stress relaxation, just know it. Intermediate mechanism, renin-angiotensin system. So we have seen this, we have gone through this. I explained. So the angiotensin 2 acts, disposes all these functions, go through this. First, it stimulates thirst, it increases sodium and water reabsorption, increase sympathetic activity, and vessels vasoconstriction, increase total peripheral resistance, venous return. In the long term, renal tubule, it increases water and sodium reabsorption as well. And capillary fluid shift. Due to the low blood pressure, low capillary hydrostatic pressure. So interstitial fluid enters into the capillaries according to a what law? We studied in the general. Refresh that. Okay. Long-term mechanisms are restoring plasma volume. So renin-angiotensin aldosterone mechanism activated restoring plasma protein because you need plasma protein to maintain your oncotic pressure. And erythropoietin production is increased. Reticulocyte count peaks in 10 days and red blood cell count become normal within 4 to 8 weeks. So these are the time durations and at what time duration which compensated mechanism is activated. So initially, there are receptors, chemoreceptors, the nervous system ischemic response, stress. Then after a minute, capillary fluid shift happening that, and this is renin-angiotensin vasoconstriction. So we just go through and get an idea the onset of the various compensatory mechanisms after hemorrhage because it can appear in the questions. Either we will check this knowledge either in MCQ, SCQ or any form. Maybe even in those three. So the compensatory reaction to hemorrhage. One is tachycardia. Tachycardia increase cardiac output, so regain blood pressure. Vasoconstriction, increase total peripheral resistance, regain blood pressure. Tachypnea increases your thoracic pumping effect, so cardiac output can increase. Venoconstriction itself increase venous return, increase preload, increase cardiac output. Restlessness is a kind of compensatory mechanism. It will increase your muscle pumping. So when they do more muscle pumping, more venous return. The hormone secretion like catecholamine, sympathetic activity, ADH, water retention, renin-angiotensin, aldosterone mechanism, erythropoietin, red blood cells production, they all have a part. So what happened in decompensated? The shock, lysosomal activity because of the acidity, release proteases, vasoactive part, hypotension, fluid loss, irreversible. When the compensatory mechanism and the medical management fail to restore circulation, patient goes into decompensated shock. In decompensated mechanism, cardiac depression occurs, mainly due to the toxins and hypoxia, acidity itself. Reduced tissue perfusion, anaerobic metabolism, lactic acid stimulation or accumulation, lactic acidosis, depressed myocardium, and endotoxins also. Progressive reduction in the blood flow to the brain, depress your vasomotor center, sympathetic activity stops. So the heart rate, vasoconstriction, everything is going to reduce. Sluggish blood flow. Due to the slow blood flow, metabolic waste result in agglutination of the blood in the vessels. It can cause intravascular circulation. Increased capillary permeability due to capillary hypoxia also occurs. Acidosis occurs and everything leads to decompensated shock. In a nutshell, reduced capillary perfusion, inadequate tissue oxygenation, shift to the anaerobic metabolism, metabolic acidosis, release of free radicals and oxidative stress, tissue damage, apoptosis, cell death. This is the basic flow chart of the general mechanism, how inadequate perfusion leads to cell death. Go through this. It will give you a concise idea. And the management of shock is very easy. You have to cause that. You have to correct the underlying. You have to treat the effect of shock like hypoxia and acidosis to restore the tissue perfusion. In hypovolemic shock, because it is the volume loss, not to elevate the foot end, you have to give oxygen via mask, transfuse fluid. If there is a bleeding, you have to give blood. If there is a burn or any other thing, you have to treat accordingly. The dehydration, you have to give electrolyte solution. Then you have to give sympathomimetics to make your heart pump and keep the vessels vasoconstricted, especially in the neurogenic shock and anaphylaxis. So you give glucocorticoids to strengthen the heart, stabilize lysosomes, and aid glucose metabolism of cells. You will give antibiotic in septic shock. So these are the nutshell for manage the emergency and definitive management. Just go through this. The definitive management varies, depends on the type of the shock. Hypovolemic, fluid resuscitation, cardiogenic, mainly we have to give the sympathomimetics to pump, like phenylephrine, epinephrine, blah, blah. And the distributive shock, you have to resuscitate and you have to vasoconstrict. So go through these are the boards. And this is again a summary, the wonderful summary. You can go through our slide and you will get an idea. And there are a few questions, just go through, it will sharpen your knowledge. And this is again a summary, the type of shocks, causes of that, and the symptoms. And you should be able to explain the pathophysiology or physiological basis of these symptoms. Hope you all are excellent students. If you have any question, you can always contact me via WhatsApp or my email. And I always say, may peace be upon you all. Thank you very much.